Thank you, Aishan, and thank you for the. Oh, I've been told to put this down. There you go. Thank you, Aishan, and thank you for the invitation to be part of this. And hopefully, it's going to move seamlessly into practice from what we've had already in terms of data. Not my strong point, and then policy and now practice. So this is my declaration of interest. The key thing really about this is that for 4 years until April of this year, I was the National Specialty Advisor for Alcohol Dependence to NHS England, at which point it was all solved. So that role is no longer there. So the nice bit of that is that I got back to the General Hospital where I actually see patients for half the week, which is great. So this is the other thing that as a psychiatrist, I really particularly like this cartoon. But when we're thinking about alcohol, I think there's often a really great divide between the public health that we've heard about this morning, the public health sort of responses to it, which is really, really important. And then the treatment services and, in some of the narratives we've heard just now, which is really, really important. And I think though, sadly, where there are limits in terms of resources, what we forget is that alcohol feeds all the way through these areas. And it's not just about primary prevention, and it's not just about sort of treatment for the most severely ill, but it is actually how do we kind of integrate the management of alcohol harms, alcohol use disorder more broadly. And it's not helped because of the way things are often commissioned or the way that as health professionals, we're trained. Alcohol, it's a tiny molecule. It gets everywhere. It's in every organ of the body. It's a poison, as we heard earlier. And therefore, actually, we need to sort of allow for the fact that it's probably therefore in every single specialty. And I think the other thing to be thinking about when we're thinking about development of health services is around the fact that we have these factors that if we are wishing to improve the access to experience of and outcomes from alcohol treatment in all of its forms, we need to remember, of course, that, alcohol is pervasive, so it fits well in what we've already had. We've got that macro level way of thinking about things, which is what the government's prepared to do or not do, as well as policymakers and society and normalization of it in society. We've then got this meso level, which is what I think of and spend most of my time thinking about these days, the health and social care services and professionals. And I think it's really important we don't forget that we bring ourselves to work and we bring our own attitudes to alcohol to work with us as well. And then micro, which is that level of the individual and their circle of concern. And as health professionals and social care professionals, that kind of face-to-face work that we do. And then round all of that, we've got those social drivers of inequalities and the wider determinants of health and health inequalities. And I was interested that, earlier we were talking about that there wasn't specific Irish data on the health inequalities. And there's a slight aside, in our NHS England work, we were able to get alcohol care teams to start submitting data to NHS England. And those ones that have done that have shown really clearly that 50% of the people seen by an alcohol care team are in the lowest socioeconomic group, and all the rest are in the higher four. So, it really is a targeted kind of intervention with regard health inequalities. So this is a kind of slightly complex slide, but I think it's kind of talking a little bit more to trying to understand the determinants of alcohol dependence and impact of any kind of specialist care in a complex and politicized system. So as I said, on the outside, on the left-hand side there, you've got the determinants. On the right-hand side, you've got the impact of any changes or policies that you might make. And then the determinants at that macro level, you can see there in terms of kind of social norms and drinking cultures, all of those things around, which you can probably see better than me actually on that slide, particularly now I've taken off my glasses. But anyway, and then at the meso level, I think there is this key thing about actually having a strategic clinical leadership. And this is something that has come out the work that I'm going to present in a minute, which is without that kind of constant reminder in the system that this is important and we need to keep our eye on the ball. Actually, some of the other things come and go and don't necessarily sustain. So you have the various things that might be happening at a health service level that we'll talk a bit more about. And then obviously there is that one-to-one action interaction with patients and service users. And I think we shouldn't underestimate that kind of humanizing of healthcare. The experience that individual people have when we meet them is absolutely key to any sort of, implementation of policy And then as we carry along to the right-hand side, you will start, when you're measuring impacts of anything that we do within a health system, we need to think about what happens to the individual patient, what happens to the health system, and then what happens in society. And those are all different time spans and also, outcome measures that will be needed to look at. So I'm going to talk a little bit about a research study that we're engaged in at the moment, which is the analysis of alcohol care teams within England. I'm going to talk to some of the international data about that. But I think one of the things that I have learned during this last 2 years is this idea of trying to separate out what is a model of care from what is an operational model. And that's not meant to sound too semantic, but essentially, an operational model is, we have this many people doing this job in this place for this long. Whereas a model of care, which is what I'd really encourage us to think about when we're thinking about alcohol, because it is everywhere, is how do we set up our health services so that they're delivered, so that kind of to ensure that people get the right care at the right time by the right team and in the right place. And we don't bounce people around, and make them really use the agency that they often don't have in that much supply to make sure that they get the care that they need. And these are some of the guiding principles for that, which this comes from actually an Australian documentation, but I found it really helpful, and a lot of this is common sense, but I think it's worth us bringing back to in an era where we have services provided, as opposed to thinking, what is it that we're wanting our patients to get out of, what are the outcomes that we want? So things about it being patient-centric, having robust and standardized set of outcome measures and an evaluation process, because otherwise, as we've heard this morning, you can just repeat things that are not necessarily that helpful. But as part of that, then you need to kind of have ways of setting the vision of the service for the future so that it remains fit for purpose as our populations change. So as I said at the beginning, I think the other thing that we really need to remember about this is that complex range that we get with AUD, alcohol use disorder presentations. And my little cube here is kind of 3-dimensional cube to try and do this on a 2-dimensional slide. But, as has been mentioned already, the severity of alcohol use. So some people, this is about primary prevention right the way through to secondary and tertiary treatment, but also the treatment of alcohol-related harm, which is my little ARH on there, that people might present with liver disease, alcohol-related brain injury, fetal alcohol spectrum disorder. All of these things might pop up, and in addition to the kind of underlying alcohol use disorder. I think the stage of illness is really important when we're thinking about a systems approach. And again, it's been alluded to this morning, is that some people are really unaware that actually what they drink is excessive. It's no more excessive than anybody else that they know. And it's only when they've come in, we've had mention of making every contact count, when they come into kind of health services and they're having a conversation about something else, that you can start to have what I would consider a kind of clinical conversation about these things. But then we've also need to include in that patients who've got real high needs, high use, sometimes kind of called frequent attenders of health services. But, they may also then additionally have alcohol-related harm, right the way through to the people who have end-of-life care needs. And I think we often, again, I know certainly in England, and my apologies, I don't know what the situation is here in Ireland, but actually for people who are at the end of their lives and are alcohol dependent, they're often not seen by palliative care services because it's not necessarily seen as part of that. So how do we manage people whose end of life is near, who are still actively drinking? And then I think, which is the lovely thing about today, is that wide range of the focus of the interventions that we might be considering. It needs to be a life skill, understanding actually how much you're drinking and where that fits on a spectrum of kind of probably okay through to really not a good idea, and having literacy, alcohol-specific health literacy, to be able to talk about that and to up that in the population, and dare I say, amongst health and social care professionals, because we're pretty rubbish at kind of monitoring this. And, we need to take those opportune moments that aren't necessarily planned, the salient teachable moment or the reachable moment when somebody's come in for somebody else. But then there is those more complex patients who are increasingly coming into healthcare later and with a combination of health and social care needs, for whom actually, I work in a general hospital now 2 days a week. You can't fix all of that in 5 days, and you can't necessarily refer on to somebody else who can even hold it as they come out of hospital. So how do we start to think about that kind of degree of integration? So just to take a step back, so alcohol care teams, this is something that we have in the UK, and they're, as I said, an operational model, which have kind of evolved like little kind of mushrooms, slightly different mushrooms throughout the country and in Scotland as well, driven mainly by local clinical champions who kind of, got on their high horse about, their particular problem in their particular hospital and wanted to do something about it. And so they've been developed really through a clinical consensus. And then back in 2019, NHS England actually committed 24 million quid, which sounds like a lot, to optimize an alcohol care team, to really try and think about how do we get these, kind of across the country in the 25% of the most needful places, so places where we had the greatest alcohol-related harm. But they did this, and this for me is a really important bit about that operational model, which was because an alcohol care team will reduce avoidable bed days and readmissions. So that's a very simple and singular and perhaps unachievable outcome for what should be a really complex kind of intervention. Now, I'm going to talk about acute hospitals, and I realize that, people from a much broader kind of range of services here, but I think the same thing can be applied to any particular part of the health service that we're in. So in an acute hospital, we'll have people in from, 1 day through to 3 weeks, but nearer 4 or 5 days. And essentially people come in with any number of things that is there on the right-hand side, in a mental health crisis, some form of alcohol-related harm, untreated TB, increasingly our older adults who've fallen and had long lives, and, strokes, et cetera, they come in, they're not seeking treatment for alcohol, but we need to manage their alcohol as part of them being in hospital, primarily because quite a few go into alcohol withdrawal, and therefore that's our primary thing that we need to manage. But that then becomes a treatable moment, and how do we then make that into a pathway for what happens after the rest of that time? So we'll pick up people who'd never thought about it before, right the way through to people who have that eureka moment, say, okay, I need to do something about it. As part of that, we were funded with a quite large consortium, which I lead together with my colleague Tom Phillips up in Hull, to try and understand what the implementation, the value and the effect of alcohol care teams were. And what I want to present to you is one bit of this, which is trying to identify the kind of the components that might go into making a successful alcohol care team. And as I said, for that, I think it's thinking about how we implement this in health services more broadly. So we've had 4 strands of work, which, because of time, I'm going to just focus on a couple of these. We did quite a lot of professional stakeholder meetings, and we sourced all of the guidelines for what would you do about alcohol. So say you've come in with, nutritional failure. There's big guidelines on nutritional failure. So what do you do with people who've also got alcohol dependence? We tech search them all for alcohol, not a single mention, lots of those sorts of things. But we did go through all of the guidelines that they were to try and sort of find those things, interviews with clinicians, academics in the area. Secondly, we did a scoping review, which I'll show you in a minute. We then kind of had already, as part of another part of the study, we'd done a survey of all 180 plus hospitals in England to find out what their provision currently was. And then we had a really significant public contributor exercise in order to go into the consensus, thinking about what was a kind of patient level kind of ideal of a model of care for people presenting to an acute hospital. So this is a fairly classic looking kind of scoping review kind of summary. So we were specifically looking for to identify models of care for the specialist management of alcohol use disorder in acute hospitals and the transitions into the community. And so we weren't trying to look at do brief interventions work, or what do you do about medically assisted alcohol withdrawal. We took specifically things that included 2 or more of those recognized interventions to see what they made as part of a model, because research often just focuses on one thing, but actually it's the knitting together of a range of things which makes the difference. So we screened lots of papers, read even more of them, and at the moment we're down to 38 studies, and I think we're pretty much stuck on that. And just to give you a brief overview, they kind of form loosely into 3, I would say, main models. The ones in blue there include universal screening as part of an acute hospital. So everybody who comes in just gets asked about their alcohol use, so that's part of it. That's what's there in blue. Within the States, they've got this SBIRT model that many of you will be familiar with, which is called screening, brief intervention, and referral for treatment. And that's not something that's a specialist service, but it's something that got mandated, and this is where the macro bit comes in, by the College of Surgeons in America. And they said, if you want to call yourself a grade 1 trauma center, you have to implement SBIRT in your hospital. SBIRTs happened all over trauma centers in America. And it's that kind of macro involvement that often actually drives these other things that happen. So you've got the SBIRT model, not particularly specialist care, but it starts to identify people and refer on. And then the other bit is the consult liaison and the alcohol care team, AOT, which is there, which you see in Canada, bits of the UK and Europe, which is like other consult liaison models. The team managing you kind of goes, "Ooh, this is a bit outside my area. Get an expert in." They send a referral. You go and manage them whilst they're in hospital and send them on. And then the third bit really is there's a DABIT model and a RAM model in Canada and down in Australia. And those are really sort of what I would call diversion models. So you come into hospital in alcohol withdrawal, somebody sees you in the emergency department and goes, "Ooh, you'd be better off going to a rapid access clinic for, your alcohol withdrawal rather than coming into an acute hospital." Of course, for that, you have to have those sort of services set up that you can send people to, which is a slight limit from where I am. But, that's the third kind of model. So when we look at the international literature, that's kind of what's described at the moment in terms of how you might model this within an acute hospital. So that was the international literature. In terms of our engagement with people with lived and living experience, we did a large piece of work, which I said I don't really have the time to go through, but as part of our proactive study, we have a PPI coordinator who herself was alcohol dependent, now 6 years in recovery, who runs all of our stakeholder and engagement exercises. And we did a real iterative process that was based around these principles of care, which we were also worked on with people with lived experience for the upcoming since 2021, UK alcohol clinical guidelines, which keep getting delayed for one reason or another. But this is what is in them in terms of principles of care, which was very much the founding principles for people who might be then, the recipient of these services. And I think really important things there, that building of a trusting relationship, reducing stigma, giving information, shared decision-making, a trauma-informed practice, and the family involvement where that is appropriate. So, I think really helpful and sensible principles of care. So we did these 4 strands of work. In April, we got together to hold a consensus meeting and brought all of these strands together. And as you can see, we involved a range of experts, including our PPI leads. And then we sort of stacked our consensus with alcohol care team nursing leads, because they're the people who are really delivering all of this and need to make it happen. So this is where we are with this, and this is what I wanted to share with you today. And also, this isn't yet published, so I appreciate not sharing that more widely at the moment. So the first thing, which as we can discuss how we did the consensus, but was this sense of you've got to have somebody at some level up there telling you that this is important and they're prepared to fund it. And that came through from lots of different places, including our international colleagues, including up in Australia, who just said, in the end, the Australian government decided they were going to invest in this. It happened. So that was slightly disheartening, but I think is therefore really important about all the policy work that goes with it and all the kind of work that Peter and colleagues have done over the years. But when we're thinking about that health system level, the things I put in blue there, in the bold and the top part of the meso level, the first 4, are the things that people, essentially 80 to 90% of the people involved, kind of said, this is absolutely essential if this is going to happen. So one was strategic clinical leadership, just having somebody there who remains in the system for however long it is and keeps kind of banging on about the same thing again and again and, keeps it live. Evidence-based protocols for the management of alcohol use disorder and alcohol-related harm. Your hospitals have got to have policies. Your alcohol care team might then kind of teach on those policies, but you need to sort of upskill the workforce using evidence-based policies. And then, as I said, ongoing training of the workforce, which kind of is like painting the Forth Bridge. Just as you've taught one lot of junior doctors, the next lot come through. It's the same with health, with nurses, every other profession. And then key to this, which I was pleased to see, was this thing about data integration. As was said earlier, you don't necessarily have data on health inequalities. Therefore, it's really hard to make the case about health inequalities. If actually you can integrate the data that you're getting from universal screening and coding of people and what they've come into hospital, you can really then start to develop that narrative on an ongoing level. So that's kind of like at the system level. And then these other ones here, interestingly, all of them were rated as essential. And I think that's partly because we had so many clinicians kind of in there. But one of the bits around this is what an alcohol care team, if you have a specialist team in an acute hospital, in mental health trust for that matter, this is what they need to do. They need to be able to assess and identify. They need to manage medically assisted withdrawal. They need to contribute to planning safe discharge and onward referral. Capacity, safeguarding and advocacy. This was an absolute essential because the alcohol care team very much felt that much of their role was not only advocating for the patient to other clinicians in the hospital, but also then to kind of, when people were making decisions about, this patient's fit for discharge, being able to say, well, but they're going to the street. Are they really well enough to spend the night on the street? Are we sure about that? Do you know what I mean? And those kind of things that other people just weren't doing for them. So the whole thing around safeguarding and advocacy, in a hospital that just now prioritizes flow because actually of where it is with the burden of things. So that came out as really important. And then obviously, provision of psychosocial interventions, although these are not well defined in an acute sector like this, liaison with other teams and provision of information. So those were the components. But I think perhaps more importantly, what came out of this process was the kind of development of a model of care. So in some ways, NHS England had set us the task of, so what would make an optimized alcohol care team? And we've sort of evolved, having done this piece of work, to the fact of, it's not probably an alcohol care team or not an alcohol care team. It is, how does your average acute trust or, acute hospital effectively identify and manage alcohol-related harm and alcohol use disorders as it comes through the door? And so what we've got is this sort of slightly interesting, the colours, I'm afraid, sort of link with an equivalent model within NHS England. But if we think about a kind of a pathway, you've got your wider pathway. As I said at the beginning, people are only in hospital for a few days, maximum a few weeks. Where have they come from? Where are they going? What role can be played in whichever part of the health service that somebody is presenting in? What can be worked on there as a really useful, positive thing for that person, such that you can maximise what might come out of it? Hospital-wide screening, I think universal hospital-wide screening, if you think of the millions of people in the UK and probably hundreds of thousands here who come into hospital each year, you just ask everyone about their alcohol use. It starts to normalise the clinical conversations around alcohol. We've said it's a small molecule. It gets into every organ of the body. It's a poison. Why aren't we asking about it when they come when they're sick with something? We should be. It should just be normal to ask about it. IBA, therefore, the evidence would suggest that 20% of people who come into hospital, 1 in 5, probably are drinking at levels that are at increased risk use. And as was said earlier, your rates are perhaps slightly higher than that. So actually, we should be doing IBA just regularly with people as they come into hospital. And then from that, it starts to become then the management of alcohol dependence in an acute setting. So your case identification. Actually, the clinical teams ought to be able to manage alcohol withdrawal. Worryingly, they're getting less skilled of it near us, but they ought to be able to manage that. And your alcohol care team, your specialist team, should start to kind of input where actually it starts to get a bit complex, where people are not responding to first-line treatments, where kind of the complex comorbidities are kind of starting to have an impact on it all. And so that's where I think you have your specialist teams, and they perhaps also do that case management as an inpatient. They kind of do the liaison, they bring people together, they check with the safeguarding, all of those sorts of things. And then as part of that, probably, and there's a slightly different evidence base, but a growing one, the idea of an assertive outreach for alcohol use disorders, that you actually have people with relatively small caseloads who can take those with the highest need and use of services into the community and do that work with them. Am I right for time? So in terms of the levels of, that's done interesting things to the font. But there we go. So it's about the fact, it comes back to the bit that NHS England were kind of saying, this is going to stop avoidable bed days. Actually, if we think about what are the outcomes for developing a wider pathway, it's not going to be about avoidable bed days. It's going to be about, actually, can we demonstrate we've got joined up pathways? Can we improve the quality of care? How many people are now going into treatment? Is it increasing our percentage of people getting into treatment because of this sort of aspect that they had? And we'd be probably looking, so I'm just taking you across those rows, column by column. And for that, we'd be probably saying, well, the outcomes we would be seeing in 1 to 5 years. Whereas when we're then talking about universal screening, and I must admit, when I was a junior doctor, the thought that I would be incanting for universal screening of things when there was far more important things to do, like treat the patient. Can't believe I've reached where I've reached. But actually, without universal screening, there is no data. And without data, also, you don't get that live data. And I think this is the ideal thing where you've got, the systems now where they are being updated. Actually, you can see people coming in, you can see their audit score, you can see what's happening, and you can actually go and intervene immediately. You don't have to wait for somebody to come and tell you about it. So I do think actually in terms of reaching the maximum number of people for the need, thinking about their model of care, they might just need a brief intervention. They might need to be prevented from going into DTs because they've come in with a seizure. They're now a bit obtunded. People don't think about the fact that they're actually in severe alcohol withdrawal until it all goes very badly wrong. So I think what this enables us to do, this model of care, is that it enables us to think about, we need to have this as a whole. It's not picking off bits of it. We need to have it as a whole, but we then also need to be really savvy about what is the outcome that we're planning for that. And some of it, as was being said earlier, some of that is qualitative, some of it is quantitative. We have lots of data, it's really important, but sometimes for the politicians, as I said, it's an emotional response. We want the story that says, actually we did this and this changed somebody's life. So I think it is a dance between that qualitative and quantitative aspect, and we need to pitch how we present the work that we do so that we can kind of improve that for patients. So I think if I just add to these bits here, this is kind of where we've got to with this. And I was asked to talk about a health system approach, but I think there is a thing about what we really need that came out of our consensus for a health system approach to be effective is you do need to have kind of strategic clinical leadership that will just, as I said, keep on banging on about it. You need trust-wide or, organization-wide kind of education and training, and it upskills people. And they, I think we miss a chance in health services where we've got public sector health services because, we're often the employed people in the most marginalized and deprived areas. And actually we have a primarily female, and I'm sorry to be gendered about this, but there is also then, you've got people who, if we're training them up as part of the workforce, also then going back home and are having an impact in the home as well. Men can have impacts in home too. But at the same time, I think, there is that we have to remember that we come as citizens to work, and we come as educated or uneducated citizens to work, and we really need to do that. So I think, that was the final bit of that. And I just want to finish with, this was something that we also thought about in terms of a framework managing alcohol use disorder, which is that you've got clinical stabilization, early recovery, ongoing care, and stable recovery going down the left-hand side there. And then there is a role for the recovery community and support processes, which is really vital in this. And that gets bigger as people get more into stable recovery, as the clinical input perhaps gets smaller and it is targeted more. So again, I don't think it's about recovery services or clinical input. I think both of them form a very kind of real role. And the one thing I do just want to finish with, and this has gone funny as well, I'm meant to be at the Action National Day today, but I'm here. And so as part of that, Action is the Alcohol Care Team Innovation and Optimization Network. It's trying to kind of drive up standards for alcohol care teams, benchmarking and accreditation. And so as part of that, we formed this community of practice so that we could be a kind of critical voice, so that we could reach a mass to actually kind of think about what should be doing in a place where nobody goes to college to learn to become an alcohol care team nurse. So it's about how we upskill professionals. And so a very large part of the action process is about kind of a community of practice to upskill people, to kind of teach them the skills to do audits. And at the moment, this is based in the UK, but I'm sure there's lots to be learned from that for people who are trying to set up something similar. And I'd be very happy to talk to anybody about that. Thank you.